Myself, Dr. Jayesh Prajapati, Professor Head Cardiology Department, UN Mehta Institute of Cardiology, Ahmedabad. So, dear friend, today I am going to discuss on vascular access closure and its complications. We know that the vascular access is one of the important thing in intervention cardiology, and we need access for almost all the procedures, like common procedure like coronary angiography, angioplasty, peripheral things. And nowadays intervention cardiology has been expanded for the TAVI and TEVAR and all. So we are taking the access from 4 French to larger French access up to 20 French or more than that. So of course there are certain limitations of the accesses, and some of the accesses are carry less complications, and some of the accesses carries complication, and we have to plan our procedures, and we have to take a access according to the procedure that I'm going to discuss, and it also its implications. So we know that arterial circulation and which are the accesses. Of course, I'm not going to discuss for the venous access, but venous access already we know that we are taking femoral vein commonly and some of the other veins for the pacemakers and all. So I'm going to today mainly focusing on the arterial access. So we know the portal of the circulation. So arterial circulation and various accesses. So common access what we are using is the transradial access, another is the femoral access, and then of course I'm going to discuss for the ulnar access, brachial access, and some of the other access that we are taking in some of the special situations like children or the neonates. We are taking the axillary access, or for the TAVI also we are taking axillary access. Sometimes we are taking the carotid access, and some of the less common access for peripheral vascular interventions like the popliteal access, pedal access for the retrograde approach, and of course there are the transcaval, and there are so many things people are doing in interventional cardiology. So there are some of the caveats of all these accesses and benefits. So I'm going to discuss mainly femoral, brachial and radial access. Some I'll touch upon the ulnar, and I'm going to discuss of the certain closure device like femoral closure devices that what we are using nowadays, like perclose, preclose, angioseal and some of the other devices, and I'm going to discuss the complication related to this one. So when we choose a vascular access site, we have to think for what procedure we are taking access. So one thing we are taking is for a coronary interventions. So mainly nowadays almost most of the people, because of familiarity with the radial and enough experience with the radial, so we are taking coronary mainly through the radial route except in certain situation. And another, suppose we are planning for peripheral interventions like renal or iliofemoral, where the multiple accesses, sometimes peripheral vascular intervention we require multiple accesses, and because of peripheral vascular disease we have to choose our access accordingly, like right or left. So we are taking sometimes the left radial or the left brachial access, because left radial or the brachial access we can use a femoral catheter same way. And of course some people are advocating the left radial access for the coronary interventions also, because of some people are familiar, and it is easy to engage the catheter, and sometimes we find a problem with the right radial access like tortuosity, or then we go usually through a arterial lucera, or so that way we are going from the left route. And of course for the iliofemoral, where suppose we are not the total occlusion, we want to take a from retrograde approach or antegrade approach, so we are taking sometimes the left brachial or left radial, where the short catheters can reach up to the descending aorta and up to the femoral. But always whenever we take a access, we have to keep in mind the length of our devices. So there are some limitations, like some of the balloon they cannot reach from the right radial to the even the femoral or the popliteal access, popliteal interventions. So where we have to take a long sharp balloon, so everything we have to keep in mind. Sometimes we do a lima, and we do everything, and we know that then the balloon length, the shaft length doesn't match at all. So then we have to cut short the guide, and sometimes there are so many ways to do it. But before planning the procedure, we have to plan our access accordingly. We have to take access, and of course another thing is size we have to keep in mind, because there are certain limitation of each access. Like radial, nowadays because of expandable sheath available, Terumo 1. So where we can take even a 6 French outer, and it's a kind of expandable sheath. So 6 French puncture can give a right to a 7 French catheter insertion is possible. So that's the radial. But of course, when we want to use a more than 7 French or 6 French, sometimes we require a intravascular assessment, or the artery size is to be assessed. So that is things should be done for the radial large size. Brachial can adapt up to 7 to 8 French, and of course femoral is one of the big advantage of femoral is that you can go with a up to 14 French requiring a perclose or a pre-close, but more than sometimes required arterial misclosure devices, or sometimes we require arteriotomy also. So one thing is that, and another thing is when we choose the access, always it is a dictum that each and every patient we take upon intervention procedure, all the peripheral pulses should be palpated. We are planning for intervention and then we find that, oh, his radial is absent, or his femoral is absent, or she has got so much atherosclerosis, or sometimes even after taking a puncture we find difficulty. There is so much tortuosity because of atherosclerosis or aged patient. So one thing is that we have to keep in mind some of the other things, other comorbid illnesses that we have to keep in mind. Like the patient is having a CKD. So CKD, there are both way around. CKD patient, they are more prone for atherosclerosis, and of course contrast limitation is there, and they are more prone for the bleeding also. So when we think for that there are the risk of bleeding is there, then of course for the and most of the intervention, if it is feasible by the radial route, then the radial route is more preferable. Because of that, I am going to discuss why the radial route. But if the patient has got a peripheral vascular disease, then we have to think that which access is to be taken. Suppose patient has got a left femoral or iliac disease, right is there. So whichever the access is pulse is palpable, we have to choose the access accordingly. And another most important thing is we have to think femoral. There are some of the disadvantages. Patient cannot be mobilized. So then aged patient is particularly a problem. Previously people were thinking that radial access carries more risk of embolization and stroke, but not so. But for the aged patient nowadays, because of femoral or iliac aorta is too much tortuous, and they cannot lie down because of back problem and because of urination problem and immobilization related issues. Nowadays radial is preferable for them also. Another thing, we have to think about the bleeding risk. Like suppose patient, we are taking, what happened nowadays, we are doing the rescue PCI, or the patient once has been thrombolized, or patient already been anticoagulated, or patient already, suppose patient got a replacement done and patient already on oral anticoagulation. So and some of the other bleeding related issues. So bleeding risk is high in such patient. It is always better to switch over toward the better side for the less bleeding risk. Is nowadays even almost all the PAMIs we are doing by the radial route. So bleeding risk, that we have to always keep in mind. Accordingly we have to choose the access. And of course I have told that liberty of the sheath size we have to be very careful, and catheter limitation or the balloon hardware limitation, that always we have to keep in mind. And of course the support, sometimes we need a more support. So always access the procedure we have to plan. Suppose what happened, suppose patient having got too much tortuous, we require good guiding support. So then we have to think whether the femoral, and they depend upon your experience, your availability of the availability or hardware, you have to choose your access. Sometimes the femoral in such cases is the better, where good support is required. We want to push, we want to exchange more and more devices, and we are not confident. In such situations sometimes femoral is better. So each and every person should have got a experience of all the accesses. One should not be dead. Nowadays people can tell that nowadays most of the people are moving toward the radial. So the fellows who are trained in radial, what happened, femoral is like a highway. What happened, you find some of the major complication occur, we required IABP, we are doing some of the peripheral interventions, even patient required support large bore devices. So then the femoral experience of the femoral should also be there. So everyone should be trained for each and every access for the benefit of the patients. So as I have told, the vascular access overview, the femoral, brachial and radial. So of course femoral is not an end, femoral is end artery or no. We have to, of course, after the profunda there is not a big thing. So suppose the patient develop a thrombosis, into the femoral, and we have to maintain the profunda. So that we have to keep in mind. Then the patient limb is lost sometime. So, but what is the advantage? Easy of access. Femoral, you can puncture it easy, but you have to be very careful. The wrong puncture or wrong puncture site can lead to a big hematoma. Learning curve is very short. Femoral is very easy to puncture. Flexibility in seat site, of course, yes, you can go up to whatsoever you need. Anticoagulation is mandatory, no, because it's a large size artery. So if you are taking everything new one, catheters and everything, and you are going to finish your procedure fast, then some say even a minimal anticoagulation like a 3000 heparin is enough, or even if we don't give any anticoagulation, it's okay. If you do a procedure, remove the sheath and puncture it. So that's the advantage of the femoral. And complication rates, of course, is higher compared to the radial route that I am going to discuss. But its femoral usual size is 6 to 9 mm. Brachial, of course, is the second option for the size wise. Of course, it's an end artery. We have to be very careful. Suppose brachial thrombosis occur and the limb is gone. So brachial, we have to be very careful while puncturing. Ease of access requires some experience with the brachial puncture, because literally deep-seated artery and brachial hematoma can lead to a compartment syndrome. Of course, it requires learning curve, and flexibility, of course, is there. You can go up to 7 French, 8 French sheet, and anticoagulation, of course, is required, because if the brachial artery thrombosis occurs, it's got a devastating complication, and complication rate relatively high. While the radial is nowadays common, everyone is choice. It's not an artery. You have got a very good collateral from the ulnar. Usually nowadays people are not doing the Allen test, and it's not an issue. But some of the situation you can do when you assess, you want to do the modified Allen test, or you have to assess it by ultrasonically. Ease of access requires some experience, but after experience, it is not. Almost 99% of the cases you can puncture the radial artery. 1%, then you have to keep your mind to switch over to either left radial or right femoral, depend on your experience. Learning curve, of course, requires some learning curve. Flexibility of seat size, but you can go up to nowadays with expandable seat. You can introduce a catheter like seatless guide nowadays available. You can go up to 7 French, or you can go to Terumo's 7 French expandable seat that is called a 6-7, outer lumen is 6. So 6-7 kind of seat you can use it. And of course, anticoagulation a must. We require at least 5000 heparin, because otherwise the thrombosis can occur and radial artery is gone forever. So requires it requires a heparin to anticoagulate radial access. And there are some of the caveats also, and complication rate is relatively lower with a radial. There is no access with zero complication. That always you have to keep in mind. No one can be master that they can 0% complication. So this already I have discussed, and these are the, now I am going to move towards the femoral access. Femoral access, you have to be very punctual. Your site should be perfect. It should not be too high, it should not be high, it should not be too low. Some people, to avoid the retroperitoneal hematoma, they are taking a low puncture. But the low puncture, they are carrying high chance of AV fistula, high chance of pseudoaneurysm, because of the hematoma. Once it get organized, sometimes that develop pseudoaneurysm from the back side. So lower puncture more prone for the, even the thigh hematoma can occur, AV fistula, and as I told, for the pseudoaneurysm is a common thing. And if you hit above the inguinal ligament, then it can cause a retroperitoneal hematoma, and that is very devastating. So that is always we have to keep in mind. So optimal access site, these are the bony landmark that you have to keep in mind. So which are the bony landmark? So bony landmark, so one is the inguinal ligament, symphysis pubis, not tubercle, and anterior superior iliac spine, and you have to draw a line, and puncture should be below 2 to 3 centimeter below the inguinal ligament. You should palpate the pulse. You should take some time to palpate the pulse, locate the pulse with the 3 fingers, and then of course you should puncture it. You are a safe zone. Another thing is the bony landmark. Sometimes your pulse is feeble. You want to take for peripheral vascular disease access. You have to divide. You have to take the bony landmarks. So you have to take a landmark as a femoral head. So femoral head you have to divide in 4 quadrants, and lower and inner quadrant, that should be your pricking site, and that you have to keep in mind. So your puncture needle entry should be below the inferior epigastric artery, and of course it should be above the bifurcation. That should be below inferior epigastric artery, above the bifurcation. That is the optimal access. So whenever you take a femoral access, one thing you have to keep in mind, patient should be comfortably lie down, limb should be externally rotated, you have to palpate the pulse. You take at least 30 seconds to palpate the pulse, locate it, give enough local anesthesia around 8 to 10 cc deep up to the periosteum and surrounding areas, and then take some time. Don't do hurried puncture, otherwise patient will move his limb, or sometime he abdomen, he take a deep inspiration, and sometime your puncture moves here and there, and your life will become miserable. So you have to take some time, common position that you have to keep in mind, and then after giving the local anesthesia, and then with the 18 gauge needle, you have to keep the bevel upwards and 45 degree. Just what is a classical Seldinger? There is a technique known as classical Seldinger technique. It is a modified Seldinger technique. So classic, you have to go through and just withdraw the needle, and once the flow comes, you have to go with your 035 wire or the sheath wire, J-tip wire, very easily. Your wire should go very easily, like one dictum in Grossman is written, that is a hot knife into a butter, that should go very smoothly inside that axis, and then your wire should go more freely. If you find any resistance, don't push the wire, always look and go, and that is the best thing. So once your wire is free, and then you have to remove a needle and then introduce a sheath. Some people, they say you put a nick, but nowadays sheath are very good, tapering sheath are available, so sometimes need not to put a nick. Otherwise you put a nick and then you introduce a sheath, so patient will not have a much more pain, and the skin elasticity has gone. And then flush the sheath and then give heparin if you want to give. So that's the thing. Another thing is nowadays modified Seldinger technique, just only anterior puncture. Just puncture it. Once the free flow comes, go with a wire and put a sheath. So that is only anterior puncture. That's also good thing. Then the backside pseudoaneurysm chances will be lower one. If you have got any doubt, always do a angiogram. And some people say that if you want to use a access, if the closer device, then always take a femoral angiogram. So one thing is that this is the common thing what we are doing it. But if you want to take a large bore access, where the chances of complication are high, like TAVI or TEVA, where you want to go around more than 14 French puncture, it is always we have to go ultrasonically guiding. People are going, they do ultrasound and then they puncture the femoral artery. So that is also, sometimes you are not able to puncture blindly, then it is always better to do with a ultrasonically guided puncture. That is also one thing. So which are the body landmark? So inguinal crease is not the thing you have to go. You have to always go with the inguinal ligament. So ligament and crease are different. So if it is someone is obese, so then crease will be different. So you have to palpate the ligament. Ligament a very rod-like hard structure. So your puncture should be below the inguinal ligament, not above the inguinal ligament. If you are in a doubt, go with the body landmark as I have told. Then fluoroscopy over the femoral head to puncture it. And either you can go ultrasonically or the Doppler guided. These are the way. So these are the patients where it is very difficult to puncture and this kind of hematoma can develop. So you can go like this way. You can put the needle and you can see that lower and inner quadrant of the femoral head. That is the most important landmark. Or you can put a like forceps and then you give a needle. So these are the things you can do it. These are the blind thing you can go. And vein is always a middle side. Artery is always a laterally. So these are the classic technique. Ultrasonically you can go 40 dilated tangentially. This is how you can visualize on a sonographically. This is a Seldinger puncture needle. This is how we can go it. And these are the various vascular sheath, and there are the color coding. You know that green is 6 French, 7 is like orange, then black, yellow and blue is 8 French, and ash color, that is and pink color, pink is 4 French. So everyone is color coded, so that way you can know it. And of course artery access, never ever take a too much puncture. Some what happen, like we are pricking like anyway 5-10 punctures surrounding. So that is not a good thing. If you are not able to, your first prick is a golden prick, that you have to keep in mind. So puncture should come in a first prick. Never try here and there. Don't make too much punctures, and that is very painful for the patient. So always, if you don't do it, then These are the something you have to think. So front wall puncture is desirable, and as I told, there should not be resistance. And another thing is that we have to suppose what happens. Sometimes there is too much tortuosity. We have to keep in mind the hydrophilic wires are a good one, like Terumo glide wire. So Terumo wire is very good wire. So when you feel a tortuosity, resistance, but you should be very familiar. You should not get tension, otherwise Terumo will stuck at the needle and everything you have to remove. So that wire should exit and should move freely. And of course, when always all days are not yours. So what happens? Suppose you are not able to prick, call your colleague or a superior that puncture is not coming. You can take help for someone. You can move from the right femoral to the left femoral. So change the puncture site. Don't prick too much. So that is one thing is keep in mind. And of course, once you are done, then the puncture should be pressed properly, and there should not be too much like your cath lab assistant or cath lab technician, or they are puncturing, they are compressing puncture like a havoc. They are giving too much pressure, and they apply tight bandage, and then sometimes patient will come with a neuropathy, femoral neuropathy and sensory loss. Very rarely motor loss also there, and sometimes distal pulse is gone. So you have to be proper puncture should be done. So what happened in India, most of the femoral, we are doing the manual we are not using a femostop, but manual compression. But that we have to keep in mind, after that manual compression, always we have to see the distal pulses. Distal pulses should be palpated, and pressure should be enough that it should not cause any problem. And these are the femostop kind of device. And of course, manual compression is requires some time, delayed ambulation, and person to person variation is there. And of course, sometimes small hematoma they squeeze and patient comes later on with too much tissue necrosis and a large ulcer. So that sterility or that part should be maintained. Skin should be always before femoral puncture. I'm not going to go thing, but local site should be prepared properly. There should not be any fungal infection, and always the groin should be clean, and it should be properly sterilized with good amount of betadine or whatsoever you are using it. So sterilization should be proper. Otherwise, local site infection is the worst thing. And suppose patient develops some hematoma, and some people they do a manual compression. Patient after 7 days or 10 days come with a tissue necrosis and a large ulcer, and that is a very dangerous thing. So manual compression, these are some of the caveats that we should keep in mind. Then there are some of the devices, vascular closure devices. They come with a 4 to 8 French puncture, a large bore puncture. We can use a per close, pre-close, like suture based devices, and up to 6 or 8 French. We can use some coagulation seal kind of device, angio seal. But of course, for this kind of devices, we require the proper puncture. Proper puncture should be there. Otherwise, at the bifurcation, that can create a problem. That can close the profunda. Profunda is one artery that should be kept patent. Otherwise, patient can come with a leg gangrene. So always when you use a vascular closure device, your puncture should be proper, and always femoral artery angio should be done. So these are some of the vascular closure devices that always we should learn that thing, how to use vascular closure devices, and everything is limitation, because sometimes use a vascular closure devices like suppose gel form, it can cause migration, can cause thrombosis, and closure devices sometimes. Then of course that kind the suture based device, some oozing occurs inside and can develop a hematoma. And suppose we require a repeat puncture, then also we have to be very careful. And sometimes the embolization of foreign body embolization that can occur, and if you are not good, nerve entrapment can also occur in suture based devices. So vascular closure devices, you should be familiar. You should also know the complication of the vascular closure devices or the limitation of the vascular closure devices. But of course, some of the advantages that large bore puncture can be closed easily. Patient can be mobilized easily after 2 to 3 hours. So aged patient it is a good thing. So everyone should learn regarding the vascular closure devices and its complications. So experience is a must for vascular closure devices. And some of the complication can occur with the devices. Large size hematoma can occur. And of course, which are the complications occur with a femoral approach? So one is of course, as I told, the hematoma, local hematoma, either retroperitoneal or the femoral hematoma can occur, and patient can hemoglobin loss of 3 gram, more than 3 gram is a major loss, and patient can develop vasovagal and patient collapse into that. So always, and it is also hematoma is one of the thing, very devastating thing. And if the patient develop him, not only patient will die because of anemia, but because of when the low blood pressure occurs, develop vasovagal and patient develop a stent thrombosis. And each hematoma or the vascular complication related with vascular, even the coronary complication can occur with that hematoma. Another thing, pseudoaneurysm. So pseudoaneurysm is one of the big thing and sometimes require either manual compression, you have ultrasonic guidance, or another thing you require either a direct thrombin injection, or you can do a coiling, or you can put a covered stent. So these are the things how you can manage the vascular pseudoaneurysm. So another thing is you can put a like that manual ultrasonic compression. That's the one thing very easily can be done. Patient can compress that neck and pseudoaneurysm, but large pseudoaneurysm sometimes requires surgery and grafting may be required. So you have to be very careful. So hematoma can lead to the ulcer, or it can create a pseudoaneurysm, anemia, and so many complications. Retroperitoneal hemorrhage is very dangerous thing. So suppose what happens, your wire can go into inferior epigastric artery and it can perforate, and sometimes extravasation can lead to the or higher puncture can do the retroperitoneal hemorrhage, and this is very people we cannot feel, but sometimes you can know it by guarding, rigidity, or sometimes you have to palpate the back and patient tense abdomen, or patient develops sometimes vomiting, repeated vasovagal, or another thing is to localize the hematoma. Is biggest thing you have to see on fluoro is the bladder shadow. If the bladder shadow is compressed over one side, moved to one side, always you have to look for the hematoma. So this is the one thing you have to keep in mind. So retroperitoneal, and that is very dangerous. If you have to do ultrasonography, and sometimes you require to do a CT angio, you can locate a bleeder. Then you have to either coil it, or you have to do a cover standing. So these are the major you can build. Is not a compressible. AV fistula, when you take a low puncture, the arteriovenous fistula, and then this fistula requires sometime you can do a closure, but requires either a covered stent or requires surgical closure. Another thing is too much pressure can lead to the thrombosis or the dissection into that, and that can lead to the compromise into the flow, and that can lead to the limb ischemia, and distal embolization can lead to the toe gangrene or such kind of thing. Infection, as some of the Indian patients, they are not poor in hygiene. They have got a groin, is not always a dirty one. They have got a fungal infection, and that infection can lead to an ulcer, and that ulcer is very difficult to. Sometimes people require 1 month or 6 month treatment with skin grafting also. Another complication is a neuropathy. When the servant or the CAT technician is compressing too much, it can lead to a neuropathy. And neuropathy, patient can come with the sensory symptoms or tingling, numbness into the lateral side of the thigh. Very rarely, sometimes motor loss also occurs, and you require EMG and CV study and neurology advice. But most of the cases is recover after 3 to 6 month time. Just we have to re-explain to every time we have to explain that it will go away. So these are some of the complication rate into various studies, but femoral always carries a complication rate of, always we have to tell the patient. So this is the complication rate. See, this is not a minor one. Always see 1 to 3% complication rate. That we have to keep in mind. That's why we should be master of femoral puncture also. So this is the thing I talked regarding the puncture. This is the bladder shadow or localized dye staining and everything you can know by this one. So this is all about the femoral axis. Then I move to the brachial axis. Brachial axis, as I have told, you have to medial side of arm, limb should be externally rotated. You always take a time, and it should be brachial artery. You have to be very careful in puncture. People are taking it like a radial also. You can take it by a cell technique. Both the way is fine. You can take a radial, but you have to compress the brachial artery very well, and you have to give the anticoagulants, and that is a must. So access technique similar to femoral artery, smaller than femoral artery but larger than radial. You must anticoagulate it. Catheter selection is similar to radial, although left brachial you can do with the same way like femoral catheter using. But one thing, you have to remove the sheath, and then you have to, after the procedure, you have to remove the sheath and always palpate the radial pulse once the brachial has been done. Then comes the radial. So radial is biggest advantage is early ambulation. Is most nowadays for patient benefit or even the doctors also, once you do a radial, you have to be very careful doing the radial procedure. But after procedure, you can take a good sleep at night, because very minimum call because of vascular complications. So radial access, we have to see the patient evaluation, we have to palpate the radial pulse, we have to keep our setup ready for the radial access. You should keep your cath lab should be equipped with like armrest and everything. We should know the technique that we should keep in mind. Another thing, this is nowadays not we are using it, but these are the modified Allen test with oximetry, and if you are not getting any pulse after compression and after release, then these are some of the absolute contraindication. But nowadays people say that routine Allen test or modified Allen test is not required in radial test. Almost no one is doing it, but you should learn. If the patient has got a patient has got a connective tissue disorder, or patient has got a history of Raynaud's, sometime then you have got a feeble pulse is there, then it is better to be done, or you should avoid it. Radial artery. Nowadays repeated radial artery puncture also can be done. And another thing is now modified one is the distal radial access. I'm not going to discuss much of the distal, but distal radial access you can do it, and sometime you can do a repeated procedure even with a radial also. You can go with a 1 or 2 centimeter above if radial pulse is there. So you can do a multiple puncture with a radial also. So nowadays people try to preserve the radial patency. And it is always, I'm going to discuss that later part, what is the importance of sheath is also. So we should know the radial anatomy. So what is the advantage of radial? It's a dual arm has got a dual supply. It is the ulnar and the radial and palmar arch. So good patency is there. So dual circulation, always very good collateral from the ulnar is there. And radial we have to puncture, that we have to say styloid procedure. There is a bony support, and there is radial advantage. What is the advantage of radial? Of course, one thing is you can compress it very easily. You can got a very good body support, very collateralized artery, and then of course one thing is that there is no nerve around. There is ulnar disadvantage is ulnar there is a ulnar nerve around. It's a little bit deeply seated artery, ulnar, and compression is little difficult. So that's a disadvantage of ulnar. But the advantage of ulnar artery is that it little bit larger size. You can take 7 French teeth there also, and less prone for the spasm, and less variation with the ulnar artery, tortuosity is less. But the radial, the advantage, as I told, there is no nerve, and of course we have to think for the carpal tunnel also. So this is the Allen test. We are not doing is so. And another thing is that palmar arch patency should be done, as I told. And sometime if we are in a doubt, we can use ultrasonically. When you want a large access, you can take a ultrasonography advantage, or the Doppler you can do it. So this is how limb should be externally rotated. You should palpate the pulse properly. Give the 2 cc of xylocaine. Mind where you should be very careful that xylocaine should not go into the intra-artery. That is one thing. So some people say that give first little local anesthesia, puncture it, and give later on the remaining local. But some people advocate differently. Give the 2 cc of local anesthesia, allow it to just 1 or 2 minutes, and then puncture. Sometimes you giving the local, you are able to you can palpate the pulse because area become wide. So advantage, and some say that sometimes you can see there will be advantage and disadvantage, both you can use anyway. So give a proper local anesthesia and give some time. Otherwise the pain will cause the spasm. So take 1 or 2 minutes after giving local anesthesia. Your puncture should be about the styloid process, and that should be the puncture point, as I told. So that should be the puncture at site. And you can do it with either routine intracath or the Vigo. You can take it, or you can take the needle inside the terumo sheath comes. That is also very good needle. It's a sharp needle. So just 45-degree bevel upwards, puncture it, and then here you have to do with a classic cell digit technique. That's what I do. So go through and through. Then you can give either a giving sensation, or you get a drop of blood inside the sheath. So then you just withdraw. Then you have to remove the needle and just withdraw it, and then the flow comes. Then the free flow comes. Then you are inside the artery. Some people, even with the intracath, is a very soft one, so you can push it inside and then introduce a wire. But with a terumo one, sometime it go into the advantageously, but intimately. But here also, once the free flow comes, put that wire comes like 018 to 021, that wire, straight tip wire, that terumo one or another one, that pass a wire, and wire should go very smoothly. If your wire doesn't go, always take a advantage of fluoro. Do a fluoroscopy and then go move ahead. So local anesthesia, first trick is always a golden prick to avoid the spasm. Multiple puncture can lead to the spasm. That always you have to keep in mind. So use a 018 or 021 guide, straight plastic coated or hydrophilic wire. Don't push a wire. So if you push a wire, then you can perforate the artery. Then once you are done with your sheath, always give a vasodilator like nitroglycerin, verapamil, diltiazem, nitroprusside, whatsoever you like. Give the vasodilator, and always use the hydrophilic sheath. So Terumo 1 is the excellent sheath, because otherwise the other sheath can cause a more spasm. So use a hydrophilic sheath, and always anticoagulant the patient. So heparin, you have to always heparin, don't inject heparin directly. In here radial you should dilute with the blood. Otherwise heparin is acidic, so patient will develop a burning pain. So dilute with the blood and then give the heparin and then move ahead. So always we have to sedate the patient. Sometimes patient not comfortable, is moving around. Sedate the patient, and of course you should use the micropuncture kit, vasodilator as I have told. You have to always take an exchange wire. So exchange wire is a must. Don't use a single length wire. All the catheters you have to exchange over that wire. Repeated exchange sometimes cause embolization and too much tortuosity or anatomy. Radial has got a variable anatomy, and subclavian loop is also there. So exchange of the catheter. So always make a habit to take an exchange wire when you do a radial. For exchange wire, either both the way, you can use a routine 035 wire, what we are taking for the femoral, either a cordis or Medtronic one, or you can use a Terumo extended wire, but Terumo wire can go anywhere. So whenever the wire stuck up, you have to always look for the fluoro. Otherwise it can go into the small mediastinal artery, and hematoma can occur in a different site what you have not thought of. And hemostasis, that I am going to discuss in a next slide, how to achieve. So these are the patient. Nowadays radial advantage in such kind of patient where it is very difficult to puncture and to maintain avoid the complications. So radial access, already I have discussed what is anatomy and all these things. You require such kind of board where you can get a good support, and you require some platform to do the procedure. So you should get a good space. You can put a small towel, and everything should be flat, and you can perform a specific comfortable. During the radial procedure you have to be comfortable enough. That is the important thing, because femoral we are more comfortable. Radial also, because of such kind of radial setup, you should make yourself comfortable one. Some people are thinking that radiation is little more, but people say that there are some advantage, disadvantage, and with experience that also goes up. So if you are comfortable with such kind of setup, then radial procedures are very easy. It is comfortable for the patient, convenient for the doctor also. So this is how. And always what I do, always keep the radial and femoral both ready at a time. You should never be confident that, oh, I'm 100% successful with radial. What happened? Any complication occurred during the radial, and suppose you are doing with a 6-French catheter and left main dissection occurs, then it's a dangerous time. So then you have to immediately shift over the femoral, and then you have got no time to make a femoral ready. So always keep a femoral ready. Even if you are very good, even at my level, I always keep the femoral ready. So femoral always keep ready while doing the radial intervention. That is always a dictum. And alternate access, you should keep in mind. Suppose right radial doesn't come, you can go with the left radial or the right femoral, depending on your choice. But always keep the femoral ready. Another thing is that sheath and everything, already I have discussed it of 100 to 400 milligram of nitro. And of course, infection part, as I have told, you have to prepare the everything should be nicely to avoid the infection at the local site. And suppose your wire suppose you get a gritty sensation, always you have to remove the wire. So wire should move freely. That always you should keep in mind. Left radial access. Some say left radial access is very easy. You can, suppose after taking access, you can make it like this, and you can do it like femoral also. And with the left radial, you can easily use the femoral catheters. And which are the catheter you can use for the radial route? So radial route, Tiger catheter is the Terumo catheter. That is a common use catheter. And another catheters for angiography, you can take routine jerkin also. You can take AL2 for the left hooking. Even the right right JR 3.54, you can hook the radial with radially also. But the advantage of Tiger, single catheter can do anything. You can do the right, you can do the left, you can do the LV angiogram. So you need, because the minimal exchange is a good thing. Otherwise, repeated exchange can lead to radial artery spasm. So that is the biggest advantage of Tiger catheter. Another hydrophilic coating that doesn't allow the much spasm. But other, suppose you are not able to hook, then these are some of the catheters you can use it. AL2, multi-purpose, JR, and for intervention you can use a Lima catheter, or you can use a extra backup catheter, or short leg pain even with a JL catheter you can able to perform the intervention with a radial route, either left or right. Sometimes the Ikari catheter is dedicated, or Patel catheter, there is also dedicated radial catheters that you can use it. So patent hemostasis, once you are done, there are something like after angiography, you can remove the sheath and you just manual compression and put a bandage, and always don't keep all the rotate, but you have to keep some gap behind, so allow the suppose some swelling occurs, allow you always see for the venous, where you have to see for the venous return. So venous return should be maintained. You should be you should keep the pressure enough that venous return should be maintained and flow should be there. You have to check that the pulse or with the oximetry. Once you shift to the ICU, the nurse should see to it that the pulse oximetry should show the pulse wave pattern into the finger. So that is and the thumb and the finger, there you have taken the radial axis. So always make a habit that after the procedures, once the compression has been done, you apply the bandage, see for the distal pulse by the pulse oximetry, that is a must. So patent hemostasis, that is a must. So you have to check with a pulse oximetry, and these are the radial bandages available. And then once you remove the sheath, and then you have to apply air, and air pressure should be enough that you should allow the venous return to come back, and the blood flow should be maintained. So patent hemostasis, these are the things you should keep in mind, and after 3 to 4 hours, then the routine bandage can be applied. Advantage, as I told, that minimum complications with the radial, patient mobility is there, outpatient, patient can go to the toilet, and post-procedure cost, of course, because of early discharge and minimum complication, and then the cost also comes down nowadays, and all hardware we can use it the same way femoral we are using it. So which are the contraindication? As I told, abnormal Allen test is the only thing where you have no pulse, that the only absolute contraindication. And another, which are the complication with the radial artery, that I am going to discuss in later part of my talk. Before that, I go with something with the radial anatomy. That always radial anatomy is very difficult, because too much tortuosity, there are radial loop. So how to track over that? You should be, there's one good atlas is also available, so where you can see such kind of thing. So either there is balloon assisted technique, or you can use a PTCA wire or the baby terumo J-tip wire. So where you can always, whenever the wire doesn't go, you have to check the chute. Don't go blindly. If you see a radial loop like this loop, alpha loop, you can go with a good technique with a terumo wire, or you can go to PTCA wire and drag the catheter over it, or you can go to balloon assisted to avoid the razor effect. Or sometimes you see a radial calcification is there, then some people they dilate and then go. Sometimes what happen, extravasation of the dye can occur, then need not to worry. Sometimes the people they go it and they finish the procedure, and then later on they shoot, and most of the time that kind of extravasation goes off. So that is the advantage of radial, but never traumatized, never taken the dissection up to the brachial level. So brachial, up to that level of brachial, you have to, above the bifurcation, you should not take the complication up to that level. So one thing is that radial tortuosity, anatomy you should keep in mind. Another area where you find a difficulty, double radial, where a small artery is going on, then you have to be very careful. You should not push the catheter very hard. Then you have to take a check chute, and then you have to go into the proper brachial artery or the axillary and subclavian. Another thing, axillary loop or the subclavian loop is there. There you should not go blindly, because where the calcium spur is there, and then you probe too much, you can embolize that plaque and patient can develop a stroke. So always stop, look and go. That is a dictum in our vasculature. So where you find a difficulty in negotiating the subclavian area or the bifurcation where the vertebral and carotid is there, then you have to take a help of a terumo, or you have to take a pigtail or such kind of catheter, and then you have to go and negotiate the subclavian part. And what happened? Sometimes arterial lucera, sometimes the variation into that part also. So arterial lucera is there. This is sometimes dangerous. You require more experience. Then you have to, what happened? Your wire goes into the descending aorta. Then you have to go into the ascending aorta. Sometimes it is difficult. So then you have to go with a LAO view. Tell the patient to take a deep breath. Sometimes you are not able to go. So tell the patient to, this is a very excellent maneuver. Tell the patient to take deep breath, and then usually your terumo wire falls into the ascending aorta because of that mediastinum, everything goes, thorax goes down. So deep breath is one useful air. Sometimes rotation can help catheter or maneuver catheter like JL or the terumo catheter. The tiger catheter can help. And for hooking of that thing, you require either a XB because it's very difficult to hook by tiger catheter with arterial lucera. Then you have to take either a XB guiding catheter for angiography, either a 5 French guiding catheter or a 6 French guiding catheter, and take a JR diagnostic for the coronary, or you can use a AL2 diagnostic. So these are the catheter you can use in arterial lucera. Sometimes very difficult, then you can either go with a left radial. So left radial thing will be easy, arterial lucera is there, then the left radial is another option, or you can go with a femoral. There is no shame in going femoral. So always learn femoral. So these are some of the variations. Radial artery spasm. So suppose patient develops spasm, you have to give again cocktail, or you can sedate the patient with the midazolam. Sometimes you rupture the radial artery like this way. Do not be panicky. Just put a wire, keep the balloon inflated. Usually that kind of seals off. So this kind of loop you can negotiate by PTCA wire and balloon assisted technique, and you can go through this. There are so much multiple loops. So multiple loops also you can straighten it up by terumo, and pushing it terumo usually straighten off. So these are the high takeoff of the radial artery. So high takeoff can occur. So then you have to go with a proper radial artery, and this such kind of subclavian brachiocephalic loops are also there. Then it is very difficult sometimes. Aged patient, these are the very such kind of loop. Then you require more experience, or change the site from left radial, and this is how you can rotation. You can get an access with the XB catheter or JL catheter, and these are the thing maneuver. These are the various catheter you can hook it. So once with good experience, you can do it very. So 100 and 200 around that require experience for the radial. Otherwise, after 200, then the less complication rate and less time with the radial procedures. So these are some of the alternate accesses that you should learn. Is ulnar access. Already I have discussed alternative, large diameter, stator course, more duplicated, and descent ulnar, and sometimes carpal tunnel syndrome. And one thing, never take a radial and ulnar both in the same patient. Never do such a nonsense thing. So ulnar artery access already I have discussed. Large bore artery, sometimes a radial will be small one. Then you can take ulnar access, and never do such things. So these are the and one thing is that always give a heparin. And one thing is that radial artery pulse lost is related with your sheath size. So always keep your sheath size to the minimum. So 5 French sheath size you do procedure diagnostic, and if your intervention is required, then go for a 6 French. Never take a 6 French directly to avoid money, because 5 French the radial artery occlusion rate is lower compared to the 6 French. So that is always keep in mind. So I will show the sheath size and related things. So radial sheath size, that always we have to keep in mind. So which special subset, then you have to acute MI nowadays because of less bleeding. This is one of the choice. Older patient, this is a choice. CTO nowadays with good hardware, you can take one side radial for collaterals, and one side you can, even nowadays 7 French access is possible, so you can do a bifurcation very easily. Complex, so nowadays with 6 and 7 French you can do a rota. So most of the complex procedure with experience you can do a rota. Even some of our endovascular procedures can be done easily with a radial access. So radial is one of the very good access that everyone should use it. So MACE rate is very important thing, and bleeding is very bad thing that always we should keep in mind. So nowadays with PAMI, primary angioplasty, This is a safe thing to do a radial access. Even with a cardiogenic shock, people keep femoral ready. Suppose patient develop people put IABP from femoral side and do the procedure from the radial side to avoid the vascular complication. So minimum femoral puncture, that should be the dictum nowadays. So everything you can do by radial. So these are nowadays most of the studies show that bleeding risk is very low, and transfusion, always any blood transfusion carries a risk of thrombosis and future event. So you want to avoid the bleeding transfusion, then radial is always the best one. That we should keep in mind. So nowadays world is moving from femoral to the radial. Procedure success is also increasing. Almost 95% of the patient you can do procedures very easily. So MACE rate and everything is lower. Even the time with experience is also lower. People were telling that femoral you can finish it off fast, but with experience both are almost the same. So that we should keep in mind. But the advantage to the both. So walk in, walk out, that thing you can do it. So some people say that transradial is to be done when the femoral is not possible, but nowadays is a reverse thing. So always we should keep motivation. Nowadays India, almost most of the country centers are doing with a radial route. Just we have to do it regularly, and then we will be master of this technique. So these are some of the dangerous things. Mediastinal hematoma can also occur. Very rare complication is that even sometimes large hematoma can cause the laryngeal nerve palsy also. Another thing is the spasm, aberrant anatomy, compartment syndrome. This is one of the devastating complications I am going to see. The compartment syndrome, I'll show the photographs of the compartment syndrome. Radial artery occlusion, that is the one thing that always, so keep the seat size to the minimum. Torsion, sometimes what happens, while removing the catheter, spasm is there, never pull out the catheter with force. Suppose the seat doesn't come out because of spasm, your servant pulls it out. Then sometimes eversion of the radial occurs. So don't be panicky. Just make yourself calm and keep the patient calm. Give midazolam or inject more nitroglycerin, give verapamil, give another local anesthesia, take some time. Then after 5-10 minutes, usually you are able to remove that sheath. Never pull out. Sterile abscesses, granuloma can also occur. These are the anatomical variation. Already I have discussed. Such kind of perforation can occur, but just apply a bandage. Most of the time it seals off, or you can put a balloon occlusion. That can be done. So these are the things. Suppose patient develop forearm hematoma, compartment syndrome. Then you have to put a multiple incision. Sometimes patient can develop mediastinal hematoma. As I told, a terum go into a small branch and develop hematoma. Such kind of granuloma can occur, ulcer can occur, AV fistula can also occur. Very, very rare complication. We have seen that even the gangrene of the hand occurs, and patient have lost arm also. So you have to never take anything lightly. Suppose patient complains that he has got a pain and your pulses that doesn't come, always call for help. Do a embolectomy, surgical help is also required. So arm is a very precious thing. So right arm is gone, then it's a havoc. So if any kind of ischemia you can notice where the pulse is not coming or oximetry doesn't show flow, always consult a surgeon and do a embolectomy and do it. This is a French size. So lower the size, see the radial occlusion versus seat size. Lower the size, higher the size, give the heparin. So 5 French size and 4 French size, the radial artery occlusion rate is around 1 to 2%. That is we should keep in mind. So an equipment entrapment occurs, retrieval of the stent. Sometimes you put a sheath. Sometimes what happens? Don't give it too much torque in one side. Then always put a wire and then derotate it. Suppose your catheter stuck into radial, go from a femoral, hold one hand and rotate from this side. So that you have to take both the axis and remove it. Sorry. Don't pull it out hurriedly. Otherwise you can break the catheter, you can avulse the radial artery. So you should behave smartly. Don't be panicky. Suppose key catheter, retrieval stent can be done easily through the radial route also. So this is an example of radial artery avulsion. So that never should be done. So these are the hematoma, granuloma, and some local site infection, and sometimes AV fistula. You can diagnose by Doppler also. Sometimes hematoma can lead to the left laryngeal nerve palsy also because of hematoma. So that mediastinal hematoma you should be also careful. So, and some of the devices are also available, but usually people give a manual cooperation on the radial belt nowadays available. Some coagulation plug are also there that you can use for radial route. Thank you so much.